request Dr. Ganpule to talk on the robotic transplant. As you know that in the whole country, there are few centers who are doing robotic transplant. Ours is one of them. And Dr. Ganpule is doing all those transplant. Now, may I request to share our experience of the robotic transplant? Over to you, Dr. Ganpule.
Thank you very much, sir. Over the next 10 minutes, I'll be giving a realistic audit of what we have progressed as regards RAKT at MPUH. Just to go into the history, in the past, pure laparoscopic approach for transplant have been described by Rosales and Dr. Modi. We are very fortunate to have him in this group today. We would also look forward to have his inputs on this particular regard. The first possibility of doing a robotic anastomosis was described by Hosnek in 2002. But the interesting part is that he actually did it on the bench, but actually it was done by Dr. Guilianetti at the University of Chicago in 2010. But these two gentlemen from India, and we should be proud of them, that Dr. Rajesh Halawat and Dr. Pranjal Modi both are credited with popularizing the RAKT technique across the globe. And picking up from these two urologists, we went ahead with our program. So a reaction to anything new is, we all know, is first is disbelief. People say that it's impossible, it's scary, etc., etc. Then we have got the critics who say that other options are available. We are doing the same thing with XYZ procedure for years together. What is the need to change? And finally, there is an acceptance. Finally, people say that it has a potential to be a gold standard. But luckily at MPUH, acceptance is what Team MPUH believes in. And that's why we could embark on the robotic transplant program. Because at MPUH, as you all know, that change is the only thing which is constant. That's what we believe. And we follow these ideals from Mr. Steve Jobs, wherein he says that innovation is the ability to see change as an opportunity and not as a threat. And this perfectly fits the bill as far as robotic kidney transplant goes. I would like to just put in a second to acknowledge these two gentlemen who have mentored us throughout our journey in robotic kidney transplants. And we even crossed the shores wherein we did a robotic transplant in Istanbul, Turkey 3 years ago. I'll just show you a small video wherein the key steps of the transplant are shown. Till date, we have done 30 transplants, and all the transplants have been done on the robotic SI platform. As we have got the new system, that is the X, we believe that there are a few advantages which will which the system will offer particularly for this procedure. As you can see, the steps are quite standardized now. First would be the dissection of the vessels, the extrailiac artery and the extrailiac vein. Following that, we drop the bladder, and here is a new term, that is engrafting. That is, the graft is removed and then placed inside the kidney. The principles remain the same, only the approach differs. We measure the length of the vein that is required for doing a venotomy. The vein is clamped, and the venotomy is done exactly for the amount of distance we want the venotomy to be done. A small difference is that we are using an CV6 Gore-Tex suture in all our anastomosis, and this is what most of the leaders in this field are also doing, for a very simple reason that protein tends to break when you are using an robotic platform. Gore-Tex suture do not break, and they are very easy to handle. All of you will appreciate the amount of magnification and the accuracy that a robotic platform offers, particularly for such an high octane procedure. You can see that the anastomosis is done with an custom-made double arm needle. Following this, again, the same principles of an arteriotomy. The majority of the cases we have done the extrailiac artery anastomosis. And then it is anastomosed end to side with the donor vessel. Again, the same principles, perfect approximation. The intima should not be left, and following this, the vessels are unclamped in the same way as we unclamp them in an open transplant. The principles remain the same. See for good turgidity of the urine, if possible, do an Doppler, and a good urine output is a really satisfying thing to see. We go ahead to rather than going into the challenges, we would go into the audit as to what we learned. I must acknowledge all the mentors who have helped us in this particular endeavor, as well as the ground force which has been helping us throughout all the 30 transplants. Am I audible? Hello?
Yes, you are.
Yes. I'll go with the main part. In the next 6 minutes, I'll be talking about what we analyzed as regards the outcome of the transplant.
Yeah, please
Yes,
go
sir.
ahead. Go ahead.
Yes. So I'll be going into the detailed audit when I analyzed all the 30 transplants. The considerations
with
will.
the internet connection.
Shall I wait for a second, sir?
Ganpule, can you hear us?
Yes, I can hear you, sir.
Well,
hello. Hello.
Sir, actually the slides are very well visible here.
Okay.
Go ahead.
But can you hear me?
Yes, sir, Arvind sir, we can both.
Okay, so I'll go ahead. So the considerations that we took into account while doing the audit was what were the apprehensions in the mind of the team, that whether the outcome will match the open transplants, what about renal biopsies post-op, what are the patient preferences, will our results match with what all 3,000 transplants we have done, and what about the complications, will be able to manage the complications properly. For that, we thought that the most important thing would be case selection. So the selected cases, we preferred that the selected cases should always be having an BMI of more than 30 to begin with, because in that way we'll be able to justify the robotic approach. Abhijit, should I wait for a second because there is some issue with the power?
Your slides and sound is completely clear.
Yes,
Then
sir.
I
I
will
think
go
you
ahead.
can go ahead, sir. You can go ahead, sir.
Okay. So going into our experience and dissecting our or doing the analysis very meticulously, you can see that on an average we are doing approximately 7 robotic transplants in an year. The first robotic transplant was done on 3rd of October 2014. Yes, sir, I can hear you, sir. I can hear you, sir.
Abhishek, go ahead. I think
Hello?
we can. Arvind, you can go ahead.
Sir,
we can hear you.
Arvind sir, please go ahead. You are visible, audible. Your slides are clear. There's some problem at Sabnis sir's end.
Okay, then I will go ahead. So the first robotic kidney transplant was done on 3rd of October 2014. And as you can see from the graph, we were doing approximately 7 transplants a year, except the last year, just because of COVID, we just stopped the program. And we have again initiated it, and the last transplant was done just a month ago. As you can see from the analysis, we have done 30 patients, and interestingly, you can see that 3 of them were less than 18 years of age. We were very meticulous in selecting our patient pool. Most of the patients had got an BMI of more than 26 because as a team, we believed that these were the transplants. These were the patients which actually would benefit from an robotic approach. Just because of the obesity, the truncal obesity, doing the venous anastomosis is a little bit challenging. We thought that probably the robotic platform would help us better. One more important point is that we selected out of those 35 of the donors were right side donors, because we thought that the shorter renal vein would be anastomosed better in a robotic milieu, because the graft would be lying just next to the extrailiac vessels, which would help us in the anastomosis. So I'll just stop here for a second to put a point on the case selection. I feel that whenever one wants to start doing a robotic transplant program, the case selection is most prudent. We decided to select patients having an BMI more than 25. We selected in all our initial cases left-sided kidneys, and preferably all the recipients did not have any comorbidities. I do agree that it will be very difficult to find such patients, but having good patient selection in the beginning will not undermine the confidence of the surgeon. Going ahead, as regards the analysis of the operating parameters, if you go into the details, you will see that we did majority of our cases were extrailiac artery anastomosis, 27 out of them, and 3 were done into the internal iliac. An interesting thing here is that the dissection time, you see that the preparation of the graft bed takes hardly 10 minutes as against the open transplant. As against the bench time was significantly higher, because we were facing a few problems after unclamping because of the uncontrolled bleeding. So the bench dissection should be meticulous, and that should be done by the robotic transplant surgeon himself. As far as the anastomosis goes, the venous anastomosis took the maximum time, just because of the reason that It is very important that the graft aligns well with the iliac vessels. That is the only reason why the anastomosis took a little bit longer. And the total operative time, if you compare with the open approach, yes, the operating time was on the higher side, just because probably you are in the early part of our learning curve. As regards the diuresis on table, it was immediate in all cases after case number 23. So yes, definitely there is certain amount of learning curve, but let's see whether it really matters as far as the outcome goes. This is something that I have already talked about. Majority of the anastomosis were with the external iliac, 3 with the internal iliac. As regards the outcome, these are the creatinine levels at post-op day 1. So for the sake of understanding, I have drawn this red line. You see that majority of the patients have gotten creatinine which are half at day 1. I do agree that there are a few outliers, like say case number 24, 17, and 5, in which the creatinine did not drop. In fact, there was some amount of ATN and the creatinine jumped forward. But what I want to highlight here is that probably the learning curve for an robotic transplant is approximately 21 to 23 cases. As you can see, that the majority of the patients in the past 5 transplants had got a good drop in creatinine. Going a little bit further, you can see that the hospital stay was 13 days. Somebody might argue that this does not differ from the open transplant, but actually because again, as we are not very confident about the initial drop in creatinine, we are keeping the patient for some longer time in the hospital, and that is the reason why it is comparable to the open transplants. What about the creatinine level at POD1? Again, drawing the line, you can see that majority of them at post POD at 1 month, you can see that majority of them have reached up to 1.5. I'll give you the mean level shortly. And these are the creatinine levels at 1 year. So again, here you can see that means on analyzing this, we feel that the learning curve hovers somewhere around 24 whenever one starts doing the robotic transplant program. And this is the latest creatinine. Now, the case number 1 is in its 79th month of follow-up, and the last transplant is just 1.5 months after follow-up. And you can see that these are 3 outliers who have not done well, or there has been some problem. So I go into the graft survival and the patient survival. As you can see, among these 30 patients, we have got 1 death, and that is actually related. It's not related to the surgical complication, but we have lost 1 patient, and we have lost 2 grafts wherein the patients have gone back on dialysis. So you can see that the follow-up ranges from you can say that it's 79 months up to 16.3, and you can see that the drop in creatinine is also quite significant. There is one objection or observation wherein they say that the warm ischemia and the cold ischemia times are on the higher side as compared to the open transplants. We do consider to this fact that yes, as compared to the open transplant, the cold ischemia and the total ischemia times are a little bit longer. Again, maybe related to the learning curve. What about the comparison with open transplant? Actually, it should be an propensity matched analysis, but as we don't have that many numbers in the robotic transplant, we just did a matched analysis. As you can see here, at 1 year, you see that the graft survival of robotic, open, and as well as overall, more or less everything match. But let me remind you that the numbers are not matching. Here it's just 30 transplants, that while in the open counterpart we have got approximately 3,000 transplants. We have got 8 patients who have reached beyond 5 years, out of which 1 patient is back on dialysis. So maybe in few months we'll be able to give the graft survival at 5 years as well. So we also have got our own share of complications. 2 significant complications were that we had to open up 1 patient because of bleeding that was immediately in the post-operative period, and in 1 patient we had placed the kidney topsy-turvy. So we did the anastomosis to the native ureter. These were the 2 major complications that we had faced. These are the 4 different approaches, one of Dr. Menon and Dr. Modi, and this is our study. We give a steep Trendelenburg, the robot docks in between, and as we do it in the same way as Dr. Modi, wherein we use an Fenner steel incision and an hypothermia graft hypothermia jacket for the same. We do not use the Prodin suture, but we use the Cortex suture. I would conclude my talk by giving the following 3 conclusions. Our experience suggests that RIKT is safe and feasible. It has got comparable outcomes as that of current standard open approach. As far as graft survival is considered in mid-term follow-up, the follow-up at 5 years will be available in the next 4 to 5 months. We feel that RAKT would give opportunity to obese patients with end-stage renal disease to have good transplant outcomes with good graft survival, with decreased surgical difficulty and complications. Thank you very much for your patient listening.
Thank you, Arvind. That was a nice overview of the robotic transplant. Now we go